All right. You guys have my screen again?
Yes.
Awesome. All right. So thanks to all the students for joining us, and congrats on the opening day of Eris. That's probably both very exciting and scary for all of you. So congratulations. It's going to be a weird season, and we're here for the wild ride. Um, you guys are joining us for our panel on social emergency medicine and community outreach today. And we've got a couple panelists who I'm going to introduce in more depth in just a second here, but you can see them up on the screen. So we start every session, and this is going to be quick today, with a quick look at our mission statement and the goals of the program, especially for those of you guys who maybe aren't quite as familiar with us. And so at our core, these are like our four guiding principles. The first is that we look to train expert, empathetic emergency physicians. We believe that sort of your calling card, no matter where you go after your training, whether that's academics, community fellowship, if you're a fantastic emergency physician, you will be well suited to do that. And so that's kind of our first principle. The second is wellness and support. And so residency can be tough. We're in a very busy, very acute emergency department. And so it's important that we maintain that balance and value wellness and support throughout your training. The third is individual career preparation. And you'll probably even hear some of that from our panelists today. But basically, the idea is whatever it is that a resident wants to do, we want to help them to get there through mentorship, through electives, through everything. And so that's another one of our principles. And the last one is always a value of on diversity and inclusion. Elise always says it best. Simply put, we think diversity is strength, and especially when you're serving such an incredible patient population, we think we provide better care when we in some ways reflect or mirror those patients. So those are our guiding principles. And we won't go a whole lot farther into the program today. Instead, we're going to pivot and talk a little bit about a social emergency medicine. And I probably don't need to put any definitions up here for the people joining us today, but let me just let a couple more people on. Social emergency medicine is basically this idea that we have an incredible perspective as emergency physicians to investigate the societal patterns, reasons behind health inequity, and to identify needs and ways to improve these issues. And that can come in many forms. Just like our residency program, it's constantly evolving, and we're going to hear a whole lot more about that in just a second. But I threw up a couple of quick pictures because I think it gives you an idea of kind of some of those things going on. The first is what makes us really unique is our location. And so I like to throw this picture up because there's a lot of people on this chat who may not be super familiar with Chicago, but we are located just southwest down here in a little pocket of the city. We actually have city below us and above us, which is very interesting. And you see this cluster of all the like level 1 trauma centers, big hospitals up north, and then there's not a whole lot down here. This is from a news article when U of C opened just a couple of years ago, but there's not a whole lot south. And if you look, this is a crime density map. Unfortunately, this map also very closely mirrors poverty in the city. But there's a whole lot of patients down here without a lot of great access to healthcare, and that puts us in a really unique place to kind of participate in the community and provide or participate in social emergency medicine. And we do that in a whole lot of ways. And so I literally just screen grabbed a couple of them from our Instagram and our website and stuff because there's too many to count. But this actually a couple of you guys on the panel here today is doing a community CPR training at the Strides for Peace downtown. This year's was virtual, but this is a walk or run to end gun violence. It kind of finishes and ends in Grant Park, which is always a blast. But Advocate had a big tent last year, and some of our wonderful docs here were teaching CPR. This is Melly, now one of our grads, weird to say that, at SNMA. She goes with Elise all the time, and really their goal is kind of spreading the word out about emergency medicine and what a unique perspective we have here, and part of that is an opportunity to participate in this social emergency medicine. Some of it is our residents participating on an individual level, and so a bunch of them shot me pictures today that they wanted to include, and so you've got Taz and Nadia and Abby. It's hard to see under these masks. Here's Abby marching down here. A whole bunch of them were participating in this March to Save Mercy Hospital, one of the Southside hospitals that's closing or partially closed already. So some of it is what they do on their own time, and some of it is a little bit more organized. And so you'll see Oyin here, a bunch of these pictures. This is from our White Coats for Black Lives Day, yeah, I guess we'll call it that. And so you're seeing members of the department over here. If I look through here, there's Dennis, one of our APDs. There's Mila, our vice chair. Oyin and Josh over here, two of our attendings, and Oyin as well over here speaking at the event. Oops, excuse me. These I grabbed from Instagram. This is our participation in the Vote ER initiative. We're getting close to an election here, and so you see a bunch of our residents carrying these on their badges. This is actually an off-service internal medicine resident that they forced to put one on her badge as well. So there you go, passion in all of its forms. And some of it can take more of a simulation role, and Oyin will probably talk a whole bunch about that in just a bit. And so before we open it up fully to you guys, oops, let me just let a couple more people in. Okay. I'm going to do intros because I think it's helpful to get a little bit of perspective on you guys and your backgrounds, as I think it may facilitate some of the discussion. Full disclosure to the med students, I let the ladies give me, I'm going to say whatever it is that they wanted me to say. So here it comes in no particular order. So Oyin is a Nigerian American born in Nigeria, but raised on the south side of Chicago. She did not come from great financial means. Her father drove a cab and her mother worked as a temp. And she says that she survived because of the community that they lived in. She is a self-described Park District kid, and every opportunity that led her to where she is today was due to community outreach programs, hence her passion for community service and outreach. She's always been interested in social EM, including her residency project. Each resident completes a project during their training, including her residency project, which was the start of the curriculum designed for our residency program, our social EM curriculum, which we can talk some more about. After her residency, she completed a fellowship in hospital-based simulation at Cook County Hospital, and she was exposed to how simulation can help with different ways of learning. And her current role is taking that training and using simulation to teach social emergency medicine to both our residents and attendings at Christ. And so that's Oyin. Will you give a wave so they can see you? There you go. Next up, we've got Tammy. Tammy is a native Chicagoan who still lives on the southwest side. She looks like she is Harry Potter under the cupboards here, but she's not on the southwest side. She became interested in social justice and medicine in college through her work in global health, and she went on to refine it with summer jobs working on education around police accountability, and has been involved with our social EM programming since her intern year with a focus on resident education and community organizing. Tammy is the RD of social emergency medicine, is that right? Thank you. Resident Director of Social Emergency Medicine is her leadership role. And she also made it clear that I need to point out that white chocolate is an abomination and dark chocolate is the only hill worth dying on. So there you go. Another important factoid to take home today.
It's very important for social justice that everybody knows that.
We're all on the same page. And then Tehreem. Tehreem, give us a wave too. There's Tehreem, thank you. So Tehreem went to medical school at Yale, where her work in curricular reform and the promotion of inclusive and equitable healthcare inspired the creation of an annual Robert Rock and Tehreem Rehman Activism Award. They named it after her. That's how you know you've made it. You didn't know I was going to provide commentary. As a National Institutes of Health Fellow, she developed developed clinical community partnerships for information exchange at Yale Hospital and identified geographical predictors of social needs to inform targeted community-based interventions for complex and vulnerable patient populations. Prior to that, at the Maryland Department of Health and Hygiene, she worked with the Deputy Secretary of Public Health Services to establish a statewide advanced directive registry through collaboration with stakeholders such as the Office of Attorney General. She received her MPH from Johns Hopkins, and she is currently the National Chair-elect of the Emergency Medicine Residents Association's Social EM Committee and a section editor at the Western Journal of Emergency Medicine. She is also a chief resident and all-around badass clinician. So I love doing these panels and these intros, but they are always incredibly humbling. And so I will move forward from there, and I'll let me get out of my share screen there. Perfect. Some of you guys have already sent me questions ahead of time, which I appreciate. Thank you for doing that. And I'll kind of run point guard and guide the discussion here today. If anything comes up, please, you can either shout it out. Some people, usually I like to prefer to type it in the comments or send it directly to me. I can do that as well. And so I'll start with a question that actually came from one of the students, just a very basic one, which is how you guys became interested in social emergency medicine. And you guys touched a bit on it actually in your bios, but I'll let you each just quickly kind of give a line or two about that or whatever you'd like to do. Tehreem, let's start with you.
Sure. Yeah. I mean, I think social emergency medicine in many ways is just a reframing of social medicine, which has been around for much longer. And I think for the most part, a lot of my just personal experiences growing up in New York City, you know, my dad actually was also a cab driver. So, I mean, you're just seeing a lot of those things firsthand and motivates you to address those in medicine.
Awesome. Tammy?
I think kind of along the same lines, personal life experiences. My dad was also a cab driver. Look at that. Growing up in the city proper and seeing kind of my classmates be stuck in the same communities that they had grown up in, just because, the cycle of violence and poverty kind of spurred my interest in that. And then in college, I wasn't meeting people that were like me for the first time. And so I think that's when it hammered at home that, we need to kind of work on these things, because not everybody is privileged enough to be able to not have that be a part of their lives. So college kind of spurred it. And then, kind of moving through medicine, you kind of see the social justice aspect of it as well. So that just kind of solidified it for me.
Awesome. Oyin?
I think at the core of it, social emergency medicine is just emergency medicine. We put the social in front of it to state that this is something that we're interested in, and to put it out there as a stamp to everybody in ER that this is what we do. But the fact of the matter is that anytime you step into an ER, that's who you are. You have no choice. You don't get to say, I'm going to see this patient based on insurance or this or the other. I don't even know what insurance people have, what insurance types they have. What I do know is the patient in front of me. And what you realize in the ER is that when you get to know the patient in front of you, you get to know more so about why they're there beyond their chief complaint and what really adds to that. And for me personally, I was the person that used the ER because we didn't have primary care doctors. I was the person that when your mom was sick, you used your own home remedies and you hoped for the best and you prayed for the best. And eventually working hard, using all of these community outreach programs to be able to get to where we are. My father still drives a cab, and I used to be very embarrassed to say that, but now I say it with pride because that's sacrifice. And for me, there was no other choice. I think that if you go into emergency medicine, you have no choice but to be a social emergency medicine doctor, because you don't get to pick when to turn it on and when to turn it off, because your patients can't either.
Thank you. I'm going to do, I did not give the intro formally. Elise Lovell's in the group as well, our program director. Elise, will you just say hi so that everybody can see you there? And then I will let you do more of a passive observer role, but at some point I may pull you in, so I apologize.
You really want to sit back and let these awesome women talk. And so yes, I'll just be here in the background, but listening intently.
And an awesome view back there. So we talked a little bit about this socially young curriculum that runs kind of longitudinally throughout the program. I wanted to talk a little bit about kind of how it started, where we are now, and where it's going. And so I was hoping Oyin and maybe Tammy can take over afterwards, can tell us where that began and where it's going.
Well, I can talk about where it began, and I think that Tammy is going to talk about how she has shaped it to be so wonderful. So I actually have the benefit of being a former resident at Advocate Christ as well. Whoop, whoop. Love my program. Okay, and one of the things that we talked about, and we being myself and Elise Lovell, because at that point, she was my APD and then she became the PD, but I also had the benefit of the fact that she was my mentor. And I would tell her, these are the things that I care about, and these are the only things that I care to discuss. And it was interesting because not only would I say that, but I had so much support to say that, hey, I want to have a conversation about race. I want to have a conversation about health inequities, and not to be met with, whoa. We really need to talk about the heart, or some other thing that has to do with the basic medicine, right? And it was instead, yes, we're going to do this, and we're going to do this in a very, very direct manner. So out of that came a 6-part lecture series that first we had with our residents, and we also presented at some national conferences. And each of these lecture series just focused on healthcare inequities and what that looks like, from patient-centered to provider-centered to systemic, and talking about how all of these things contribute to each other and contribute to who your patient is and who you are, and what biases you bring into that relationship, what biases they bring into that relationship, and how that affects their health. And from there, it has grown. So I'm going to shoot it over to Tammy.
Yeah, it was a pretty overwhelming thing to receive, because there had been so much work. Oyin is the reason that I came to Christ, essentially. I sat down with Oyin on interview day, and she was like, listen, I don't care where you go, but I like you, and this is what I'm doing. And I was like, well, I feel like a lot of programs aren't doing social emergency medicine education. And she was like, that is the opposite of what I'm doing. Here's what I'm doing. And so I basically came to Christ so I could work more with Oyin. But she had that support already, and kind of the groundwork was laid. And there was an understanding amongst residents, like, yeah, this is something that we're interested in and we do want to learn more about. We just kind of don't know where to start. So intern year, I was given all of the lectures that Oyin had started. She was off at fellowship doing really well. And so adjusted kind of the content and the frequency of lectures to kind of, suit the schedule that year. And so me and the chief sat down and ended up deciding that 3 to 4 lectures a year to start would be a good idea, with the potential for more as we kind of saw this expanding. And so the topics, I really leaned heavily on the residents, because, ultimately resident education is going to be what we make of it, right? But the topics that they were interested in were the same topics that I was interested in. I was polling them every once in a while, like, hey, are you guys interested in learning about how immigration status affects care in the emergency department? Are you interested in learning about race? And they were overwhelmingly. So it was pretty easy from that perspective. So I think intern year into my second year, sorry, this is my third year, intern year into second year, we had about 5 lectures covering those topics. We had a couple of guest speakers come in, one from a local immigration center, one from the Trauma Recovery Center, which we have a really strong relationship with through Oyin and through Tehreem. So we kind of leaned heavily on expert speakers in the beginning. And after a while, I was hearing from residents, well, this is kind of over our heads a little bit. Can you dumb it down for us? So we went back to the basics of, what is social emergency medicine? What is social justice in medicine? What is the history behind it? And kind of what we were going to focus on. So this year, our plan is for, I think I'm scheduled for 4 or 5 social emergency medicine lectures. We had one earlier this year that was on the topic of language justice, which is huge for me. And we do have kind of resources that come from, other programs and universities that have been doing work on social emergency medicine and have kind of a structure and, basically a syllabus already available. And I've been pulling from our residents to kind of see what they're most interested in. So in terms of where it's going, so far it's going well. And where I would like it to go eventually is to be kind of a series of lectures and activities, interactive stuff mostly, that the residents can engage with during conference, and that we eventually are able to share across the kind of Christ system. So the PEDS residents have expressed interest in this. The IM residents had no idea how to start it, so I sent them all of my stuff. So eventually we're hoping for kind of intersectional resident education component to it. So.
I just want to add also, which Oyin, not surprisingly, is also involved with, is the health inequity simulation we're working on, which would be an entire day really of cases addressing social needs that are particularly pertinent for us, serving the patients we serve in the south side of Chicago. So that will be a whole day next month. And a big piece of that will be really having all of our interdisciplinary partners come with the intention of really thinking critically about how to streamline our ED workflow when it comes to really addressing these different determinants in an efficient and effective manner, and really strategizing about how we can continue to improve, especially with, unfortunately, what we'll continue to see with COVID is a greater need with respect to both mental health, but also as people become unemployed and inevitably become then food insecure, housing insecure, and so forth. And then we also actually have a couple of grand round speakers coming up later this year, specifically talking about racial disparities that emerged with the COVID-19 pandemic, especially here in Chicago, and the limitations of practicing race-conscious medicine as well. So it'll continue to grow, but we're excited for everything that's coming up this year.
It's kind of incredible this year how it's, you know, taken off on an institutional level, right? Like everybody was kind of doing their own thing within their own program. Like PEDS was doing their own thing, IM was doing their own thing. I don't know what Advocate as a system was doing prior to this year, but it's really just taken off, and the amount of resources that have been allocated to us to be able to do this. Like I could ask for anything I wanted at this point and probably get it.
Let's try that out. I think that's so well said, though. It's so interesting. Like, I just like Oyin, I was a resident when Elise moved from APD to PD. But I think back even to our training and how there was not nearly as open of a dialogue on some of these issues, and certainly less training or more formalized kind of work. And you know, I think back to the conference discussion we had following the George Floyd and Breonna Taylor killings, kind of the whole discussion on race and police brutality. You know, that's something that I don't think happened in a lot of programs, you know, a couple of years ago, certainly not a decade ago. And to see it sort of getting institutional backing is pretty great. I think, you know, Advocate Aurora is a huge health system, but to see they're interested in it is really, really cool. I'm gonna, Tehreem had talked about this a little bit, but one of the students had asked specifically, Oyin, by the way, Oyin just side texted me and asked if this session lasted 1.5 hours. It only lasts 45 minutes, but her Twitter is on the bottom there. And so you can reach out to her at any time if you guys want to keep talking. She'll be happy to. But one of them asked specifically, you know, simulation is a very trendy topic, social M is as well, and you are kind of in this unique position of marrying the two together. Where did you get interested in that? Where do you see that going?
Okay, yeah, absolutely. So simulation is fantastic. I love sim. I think that it's the best thing since sliced bread. I think that it allows to learn in a very, very safe environment, but also safety for the students learning, for whoever is participating, as well as what's more important about the debrief. The thing about classical simulation is, you know, what you're seeing and doing in medical school is that, you know, you're working on a case and you're going from there. But simulation is so much beyond that. So when you see a standardized patient, that counts as simulation. So there's a whole avenue now with a very small group of people, myself included, who are working on developing social simulation curriculum. So social simulation curriculum is basically how do we take topics that fall under social medicine, social emergency medicine, and simulate them in a way that fosters discussion and fosters learning. And without giving away too much, because I have my residents here and they do have a case coming up, it's really interesting of how you can marry the two. Not only is it possible, but it's very exciting when you want to talk about topics that has to do with the healthcare of specialized populations. You know, how do you address those things? And using simulation and using the debrief to kind of address those things. Obviously, I'm no expert, so part of what I do also in these debriefs is that there's also going to be a content expert, either somebody who identifies themselves as a patient of one of these special populations, or someone who's a clinician that treats these specialized populations, so that way they can aid in the debrief and kind of be the content provider. And while they provide the content, I figure out a way to make it simulation. I'm really, really excited to start this. There's going to be several of these simulations. The first one is actually starting in November. So ladies, watch out. But it's really, really exciting, and it's fun and it's safe, which is the most important things, because we want to make sure that we're having these conversations. If you never have them, when you have a patient who actually has a true issue, you're going to be uncomfortable. So we want to take away that discomfort.
Tehreem, I'm gonna ask you here. We did your intro, and it's longer than I could ever hope to accomplish already.
Which, to be fair, I did not write for this panel,
No,
but I just wanted to put that out there.
The problem is, if I actually didn't even give Tehreem the option because I knew she would send me a one-liner, and I just wouldn't do her justice. So I actually wrote this for her. Sorry. But you have an interest in advocacy as well, and I wanted you to comment a little bit about kind of how you've been again kind of working that in during residency and where you see it going afterwards, and maybe how your training helped prepare you for your future.
Yeah, so I think for me, in many ways, the way advocacy really manifests for me has transformed. And so specifically just thinking about how we can better advocate for patients within the clinical setting as well, and really, thinking about how to get buy-in from different stakeholders outside of emergency medicine as well to make that happen has been a big passion of mine, something I want to continue working on moving forward as well. And then the other thing, of course, is for me, training of future physicians is so key when it comes to really mitigating a lot of mitigating the impact of bias on how we take care of patients, and really being able to effectively address structural determinants. So through the curriculum work that I've done previously and continue to do in residency, that's been a big part of it. But frankly, I think one thing that we are working on as a program to improve is our community-based advocacy. And so that's something that was like a big point of discussion and brainstorming at our just most recent retreat that we had earlier this year, in terms of thinking about partnerships we already had and how to really optimize that and be there for our surrounding community.
Sorry, go ahead.
Sorry, I just really wanted to add to that a lot of the work that gets done in this program is very resident run and resident led and resident fostered. So I'll just drop an example. One of our interns, she's not on this conversation, but Donna, she basically reached out to me, said, hey, I want to do more in the community. And given the role that I have with some of my committees, I was able to connect her with the systems director of our community outreach. And they're going to start working on projects together, not just for our residency program, but for all the residency programs across the institution. And that's just something that she's interested in, and that's the type of program that this is. You say, hey, I want to do this, and someone is going to connect you with the right person who's doing that, or that person might be that person. Whatever your passion is, there's going to be somebody here for you that's going to foster that passion and that's going to guide you through that process. And I think that that's one of the really unique things about this program, is that people just don't say things, they're actually doing it. And I would challenge you all that, obviously I put my social media, but to actually follow and see what some of these programs are saying about themselves and what they're putting out there, what they're putting about themselves publicly. And you really know where they stand on some of these social issues. We're in a very, very critical time now where silence is not okay. And you have to be bold to be able to express your opinions and stand by those things. And one of the things about this program is that regardless of where you lie, everyone's opinion is welcome, everyone's thought process is welcome, and as long as it fosters good, healthy discussion. And that's why I'm so proud to be a part of this program. But also, these residents are fantastic because they take a ton of initiative themselves. They come with some type of something that they think is so little, and it gets blown up into this amazing piece of work that I'm just so very proud of them for. So good job.
I've been consistently, and I shouldn't be surprised, right? Like, emergency physicians are the people who are on the front lines, who of course would be the most passionate about it. But I'm consistently pleasantly surprised to see how our residents kind of respond to these initiatives and the things that they come up to me and request. So a couple of years ago, we had a sit-down discussion after a conference about, well, what does community engagement look like to you? What do you guys want to see? What is it that, we would, within the constraints of training and all of that, be able to do? What can you dedicate your time to? And it was like somebody had, opened up the dam. Like, people came flooding in with ideas, and it was incredible to see. And, some of those were they had been engaged in before. Some of those were activities that they had been engaged in before and wanted to kind of see continued professionally and kind of on an institutional level. So I know Josh Sherman and I had been working on collaboration with local schools, like a local high school and a local elementary school, to kind of bring the social justice and emergency medicine curriculum into the classroom and, see kind of what their needs were in terms of health education and community outreach and that kind of thing. And then schools went on strike and derailed that plan, and then COVID happened and derailed it again. But we've picked it back up essentially now, and we're in conversations now with local high schools and local elementary schools to kind of see if we can bring our presence virtually too, which is really exciting. So you know, we certainly have not let the conditions of 2020 kind of define what we can and can't do. And we're just like constantly figuring ways around it because, you know, we're emergency medicine. We MacGyver our way around everything. So
I knew that you guys had tapped the brakes a little bit, but that's awesome. I didn't realize you were looking to do it virtually. So sorry, Elise, go ahead.
I was just going to add, this is maybe just my time to make one plug, and that is, you know, what you're hearing, I think, from all of these panelists is the amazing energy and enthusiasm and drive and commitment to this cause. And just as a program director, you know, what I will try to always add is resources, right? So we definitely are in a place now where we are obtaining more resources institutionally, but from a program level, you know, I'm very committed to making sure that any programs or ideas that our residents or faculty can come up with can have resources behind them. We do have, you know, an EM foundation that has some financial resources that we've applied, you know, to some of these efforts. And I will say that our residents also have been very successful at obtaining different grants and winning awards, quite honestly, from ASAP and other institutions to further this very important work. So I will stand behind that. I will write the letters. I will get you the money because again, this is critically important. And I think, you know, now more than ever in the times that we're living in. So that's my little plug from a program standpoint.
I think there's been like tremendous growth even in the last year in this area. And a lot of that is there's so much overlap when we talk about this stuff. But like, you know, you heard Tammy say how a lot of this originated at our retreats, right? So our retreats, like much of our program, is very resident driven. In fact, it's almost unformatted. And so it's largely just small groups where the residents are bringing us ideas. And at this program, everything from changes in rotations or curriculum to things like this tend to start at the residents, at least the really good ideas. And so that's something that I think Elise is always been supportive of and certainly one of the strengths of the program. And you know, when Tammy unfortunately leaves us, it'll be interesting to see what the evolution is afterwards. But I think that energy is really important.
you can't get rid of me that easily.
Yeah.
Exactly. I want to say that the good thing about it is that there are multiple Tammys. You know, I mentioned some of our interns, but some of our second years, some of the projects that I've done have been brought to me by the second years. So this is a program where in every class, there's never going to be a dry spell. There's never going to be somebody that's not into this because this is just what we're about. And the way, and it's going to be, Tammy will even eventually, you know, gift her curriculum to somebody else and they'll take it, they'll make it into something beautiful, you know, and something continue to be educational. But that's really what we're about at this program.
Well, yeah, and I think you said it great too, which was even when we do these open discussions, like it's not all about everybody agreeing with your opinion or my opinion. It's that those opinions foster discussion. And I think that was one of the coolest takeaways from that most recent discussion we had, is that we didn't all agree, but it was cool to be at a program where at least we could like respect each other's opinions and kind of grow together from that. So that was really cool, I think. Mm-hmm. Quick question. One of the students asked what the Vote ER campaign is. They saw those pictures and stuff. Does one of you guys just want to tell them what that is really quick?
I can. It's just really quickly. Basically, we're registering people to vote, and we're asking it as part of the social history. So it started as part of the DE&I committee. Actually, one of the pediatricians started the program up at one of our other sites, and then it's a really easy program. It's through the voteer.org. I want to say it's not .com, .org. And basically you can get your own like name. So we have advocate on ours and your own text number. And what that allows with this QRS code is that someone can easily say, hey, you know, do you smoke, do you drink, whatever, are you registered to vote? And people will either say, I'm not sure, or I don't know. And they can simply put their phone up to it. And while they're waiting for their results, while blood is being drawn, you know, while they're waiting in the waiting room, we even have posters put up. They can figure out if they're registered to vote. If they are registered to vote, it can tell them where they can vote, you know, where their voting site is. If not, it also gives them the option to register to vote as well as to apply for mail-in voting. So it was just a really easy thing to do. And the amazing thing about it is when I hear from the residents saying, I registered 4 people today, you know, one of the first people that I registered was one of our security guards who was an older African-American gentleman. And he was like, this is going to be the first time I'm voting ever. And I had to stop myself from telling him the history of the work that our ancestors did to allow him to vote, because I didn't want to guilt trip him, as opposed to, I just said, you know what, this is going to be a fantastic time for you to vote.
For you, that was, it's hard for me to imagine you.
Really hard. It was really, really hard, because I was like, man, look. But then I was like, okay, you know what? This is what this is for, you know? And it was good. It made me feel good.
I put up a picture earlier of kind of our unique location, and we haven't touched a whole lot on the Trauma Recovery Center. Oyin, will you maybe talk a little bit about that and kind of the unique opportunities there?
Oh, absolutely. So the map that Cerrone originally put up, I'm going to just kind of let you guys know that it correlates with everything. It correlates with high COVID rates, high COVID deaths, poverty, low income, high trauma, IGSW, food deserts. So every single thing that can be bad, it goes with it. And every single thing that can be good, it does not go with it. So we are situated in a space where we take care of all of these patients that can't go to the north side, you know what I'm saying? And they shouldn't have to, because that's what a hospital is for. And one of the things that the Trauma Recovery Center does is that anyone that you as a physician or a nurse identify as being a victim of trauma, and not trauma in this just only term of a GSW or something like that, but somebody who's been touched by trauma. So whether they've been a victim of rape, or whether they've been a friend of a victim of rape, anything that could possibly have a traumatic effect on this patient, they basically can go to the Trauma Recovery Center with a simple referral. They'll call them, they'll make them an appointment. Now they're doing everything virtually, and they can have free therapy. They can have, when they were actually physically a body, they would actually watch people's children while they did therapy sessions from both therapists as well as psychiatrists, get the medications. They can do housing. They can come up with an escape plan if a person is a victim of domestic violence, and go through that whole process. They can offer food stamps. They actually do a GED program. So this center, this building, that there's one, but there's several others across the Advocate Aurora system. It's run by one of our psych-Ds, Dr. Kim Miller, and Blair as well. Sorry, Blair is a personal friend of mine, so I'm a little bit very biased about Blair. But they run this incredible organization that you can send anybody to, and you know that they're not going to get left behind and they're not going to get forgotten. In addition to that, they can always refer them back to the medical doctor in case they worry that something else is going on medically, as well as from the psych perspective. So it's just been a great partnership to have. Before COVID, we were working on our residents actually starting to rotate there, but we're gonna figure it out. Still working on it.
As a resident who has referred almost every other patient to the Trauma Recovery Center, you know, they came and spoke to us and they were like, hey, if we need to hire more staff because there's more demand, we'll just hire more staff because there's more demand. So, I mean, it's super important work that's being done. It's interdisciplinary work that's being done. It's work that actually, you know, you can see directly impacting the lives of our patients, which is, you know, not rare for us in the emergency department. But, you know, patients will come back to me and be like, I didn't know this existed. And I'm like, well, you're welcome. Here, spread the word, you know. And you can definitely see the difference that it makes in their recovery from, you know, whatever traumatic event happened, to, you know, getting the support that they didn't even know they needed, to identifying their needs and all of that. I mean, the assessment that they do is so extensive and the resources they have are so extensive that it is almost a crime not to find a reason to refer someone to the Trauma Recovery Center.
And that's not something to take for granted. It's really, really nice to see how well supported we are, not just with the Trauma Recovery Center, but we have many other people who have easy access to the emergency department, ranging from the community health workers or care managers or substance abuse counselors, and the list goes on. And it makes a big difference when you're really coming to serve the population we serve, and not, you know, walking away feeling disempowered and that you weren't really able to intervene in the way you wanted to intervene, which I think is key to prevent yourself from feeling burnt out. So that's a really great asset that we have access to. And then following up on Oyin's other point too, you know, the other beauty of working at Christ is our department is very well respected, but we also are given the opportunity to really think about scaling up some of our work at a system-wide level. And Advocate Aurora is one of the largest health systems in the country. So I think that's a very unique opportunity that we have as well.
Oyin pointed this out. We're coming very close to our end here. I want to be respectful of everybody's time. And so I'm going to ask one last question real quick, and then we'll kind of start closing down. But when that happens, some of our panelists will stick around. If anybody's got any other questions, even just openly, a lot of these have been coming on the side, but please feel free to shoot us with those afterwards, after we formally finish here. But our hashtag for the year at the program is the ACMC difference. And I like to finish these. It's weird, Tehreem and Tammy, but you are winding down quickly here. It doesn't have to necessarily be socially unrelated, but as you approach the finish line, what is the thing that kind of you value most in your training, or the thing that you like most about being at Christ? Tehreem, you go first.
I think the mentorship and the very close relationship we have with our attendings is very important. We work one-on-one with our attendings in the clinical setting, and we'll often hang out with them in a social setting outside of the hospital, which is really nice to form relationships through. I just had dinner with our vice chair a couple of days ago, and so I think that's very unique in terms of walking away feeling that you do have a family at work and outside of work.
Tammy?
I couldn't agree more. I just want to also add that I think the ACMC difference is definitely the passion that we have, and the fact that we are so moved by our passion to put that into action. I think that's something that's come up time and time again, throughout my training, throughout my personal experiences, throughout seeing, all of my residents achieve their wildest dreams at this program, not just personally, but, also professionally. I think that's kind of really what sold it to me, and what continues to sell it to me every single day is just seeing a group of extremely passionate people actually making a difference in the lives of their patients and in the lives of their colleagues. I mean, it's just something incredible to see every day.
Thank you guys so much for being here. We will formally wind down. For the students on here, if you want to reach out to them on social media, you can find us on Twitter, on Instagram, online. Everybody here is active there as well, so please feel free to reach out. And then as you guys start leaving, if anybody wants to hang around and ask any other questions, please feel free to do so. But we appreciate your time. It's going to be a weird season. You guys are going to do great. Congrats on making it this far, and good luck. Thank you to all the ladies here too.